All right, my name is Sam Secord, and today is May 14th, 2020. Okay. This is the Biochemistry Unit 4 case connection assignment. I chose case 1 and case 3, so let's get started. Case 1 is describing a newborn girl who appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects she has a metabolic disorder and orders a panel of labs. We're basically just supposed to answer the questions, trying to distinguish which diagnosis would be best between a urea cycle disorder and a disorder in the beta oxidation pathway. And then we're supposed to answer a question about the orotic acid levels being elevated and which enzymes will be least and most deficient. So let's get started. Let's first describe both urea cycle and beta oxidation to determine the best diagnostic tool that will help us distinguish between them. The urea cycle, strictly speaking, is a biochemical process of converting the highly toxic ammonia to a urea to be excreted from the body. This cycle takes place in both the mitochondria and the cytosol of the liver cells. After the urea forms, it is entered into the bloodstream, filtered by the kidneys, and will eventually be excreted in the urine. Let's take a closer look at the 5 steps of the urea cycle. In the first step, the ammonia produced is produced in the mitochondria is converted to carbonyl phosphate by the enzyme called carbonyl phosphate synthetase 1. The second step involves the transfer of carbonyl group from carbonyl phosphate to ornithine to form citrulline. This step is catalyzed by the enzyme ornithine transcarbamylase, which is OTC. The resulting citrulline from step 2 is released from into the cytosol, where the last 3 steps take place. The third step is catalyzed by the enzyme, excuse my pronunciation, arginosuccinate synthetase, which uses citrulline ATP to form citryl AMP intermediate, which reacts with an amino group from aspartate to produce arginosuccinate. The fourth step involves the cleavage of arginosuccinate to form fumarate and arginine. Arginosuccinate lyase is the enzyme catalyzing the reaction. Finally, in the fifth and last step of the urea cycle, arginine is hydrolyzed to form urea and orthonine. This is catalyzed by arginase. The most common disorder associated with the defects of the urea cycle is hyperammonemia, which is described as excess ammonia due to buildup in the blood from elevated amino acid levels. Elevated amino acid levels will result in excess nitrogen buildup as ammonia. Nitrogen is mostly formed from amino acid breakdown and muscle catabolism. Disorders can occur when there is a malfunction or lack of either the 1 synthesizing enzyme, the 5 catalytic enzymes, or the 2 transporters responsible for excretion of nitrogen as urea. Testing to diagnose these disorders of the urea cycle include plasma acid test, a blood ammonia test, and a urinary acid test. Now moving on to beta oxidation. If we recall from earlier back in previous biology classes, beta oxidation is the multi-step process in which fatty acids are broken down to produce energy, or ATP. Fatty acids enter the cell via a transporter on the cell surface, and once in the cell, a CoA group is added to the fatty acid by fatty acetyl-CoA and synthase. At the end of the process, the resulting acetyl-CoA group will enter the mitochondrial TCA cycle. The NADH and FADH2 produced by the fatty beta oxidation in the TCA cycle will be used by the electron transport chain to produce ATP. Disorders of beta oxidation can occur at any age and are often fatal in the first few weeks of life. The disorders can result in decreased energy production, and clinical presentations are common regardless of age. They include lethargy, vomiting, cardiomyopathy, hypoketotic hypoglycemia, and renal damage, among others. The most common fatty acid oxidation defect is the deficiency of the enzyme medium-chain acyl-CoA dehydrogenase. Deficiency in this enzyme will cause a buildup of fatty acid due to the inability to break down lipid fats. One of the options given, plasma glutamine is the best diagnostic indicator to distinguish between urea cycle and beta oxidation disorders. Plasma glutamine levels will be different with each disorder, making it an ideal diagnostic indicators. With urea cycle disorders, glutamine levels will be high, but in beta oxidation, glutamine levels will be normal. Glutamine is a non-essential amino acid, and it plays a role in the transportation of ammonia. Glutamine levels are directly correlated to ammonia levels. The most common urea cycle disorder is called ornithine transcarbamylase deficiency, OTCD. OTCD primarily affects male individuals and can come on quickly after birth, causing hyperammonemia. OTC is genetically inherited X-linked disorder where orotic acid is produced from the converted excess carbonyl phosphate. The carbonyl phosphate will accumulate in the mitochondria and then move to the cytoplasm, where it will be redirected into pyrimidine synthesis, where then orotic acid will be produced and levels will elevate in urine. Therefore, ornithine transcarbamylase will be the deficient enzyme. Conversely, carbonyl phosphate synthase 1 will be the least deficient enzyme due to the production of orotic acid and the increased efficiency of OTC. Okay, what a mouthful. Moving on to case number 3. This is presented to us as a 47-year-old man with severe pain in his right toe. He is unable to bear weight on his right foot, and there was no apparent trauma. Basically, what happens is he gets diagnosed with gout, and we're just basically supposed to explain what's the best presentation of gout in this individual and why the other choices that they give us are not consistent with the data. And we were given a data table showing urinary uric acid levels and plasma urate. So anyway, like I said, as we were told, the patient is diagnosed with gout. Let's describe it. Gout is a condition directly correlated with uric acid levels in the body. It can be caused by either too little uric acid released by the kidney or too much uric acid produced by the body. Gout is characterized by sharp, needle-like urate crystal formation and accumulation, resulting in painful inflammation of the joints where the crystals accumulate. Other side effects of gout can be brought on by factors including diet, which we'll find out is pertinent to this patient, weight, pre-existing medical conditions, and family history, age, and gender. Preventions include a diet with reduced purine intake and no alcohol ingestion. And treatments may include an anti-inflammatory drugs, medication to control uric acid reducer. One such medication is allopurinol. It's the most common, and it's an isomer of hypoxanthine. Allopurinol is a substrate for xanthine oxidase, but the product binds so tightly that the enzyme is unable to be oxidized in its normal state. So what happens is uric acid production is diminished, and xanthine and hypoxanthine levels in the blood will rise. These are more soluble than urate and are less likely to deposit crystals in the joints. So we were asked to identify the best explanation and the root cause of gout in the individual. But let's first discuss the two choices that are not the root cause. First, overproduction of purines is not the correct choice because although some purines are produced in the body, much of the purines are taken in through our diet through ingested food, such as steak, organ meats, and seafood. In this patient's case, his unusually high intake of a beverage that has a significant amount of high fructose corn syrup will account for the elevated levels of uric acid that would be produced from purines. There is a direct relationship between fructose and serum levels of uric acid. Hyperuricemia is caused by the overproduction and or underproduction of uric acid. It has been reported that the metabolism of fructose stimulates uric acid production, since transient ATP depletion commonly occurs with the generation of AMP and reduced uric acid excretion. In addition, the elevated plasma urate levels will account for increased purine intake, not production. Decreased salvage of purines is also not the root cause because the patient is getting a significant amount of purines from the fructose and from the increased soda intake, and the corresponding elevated plasma urate levels correspond to high amounts of uric acid production from purine intake. As the table shows, the patient is excreting about 50% of the normal urinary uric acid levels. So we know that the root cause, and we know that that is the root cause and the best presentation of gout in the patient. Thanks.